Today I'm speaking one of our most interesting sessions, I think, with Dr. David Putrino from Mount Sinai Hospital, at the forefront of the COVID battle. He's in New York City in the hospital. So first of all, good morning, David.
Good morning. Thanks for having me.
Thanks for being here. And a little bit of information about David. He's a physical therapist with a PhD in neuroscience. He worked as a clinician in Australia before moving to the United States to study neuroscience at Harvard Medical School, MIT, and NYU. He served as a faculty member at Weill Cornell Medicine and Berkeley Medical Research Institute. He's currently the Director of Rehabilitation Innovation for the Mount Sinai Health System and an Assistant Professor of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai. He works to develop innovative technology solutions for individuals in need of better healthcare accessibility. He consults with the Red Bull High Performance Division to use evidence-based technologies to improve athletic performance. He is also the chief med scientist of Not Impossible Labs, a group that crowdsources accessible technological solutions for high-impact humanitarian problems. David's research has been featured on the ABC, Sports Illustrated, the Wall Street Journal, and others. So first of all, good morning. We are not so far away from one another. I'm in Rye, New York. You're in New York City. So we're going to have a general discussion about how Mount Sinai has responded to the COVID-19 and led the world in many of the aspects of response to the pandemic. So I guess my first question would be, what has it been like to be in the hospital during this time?
Yeah, I mean, I think that's a pretty fair starting point for what we've all been through. It's been a very unique experience. In many ways, it's been really, really harrowing and hard to get through. And then in many other ways, it's been really impressive and amazing to see how an entire health system has come together to serve a city, to have all of these frontline workers and essential workers, putting their own safety, their personal safety on the line to make sure that the city of New York and from everyone around could get through this crisis together. So we've had a lot of high points and a lot of low points, I would say, it has been the experience here.
And by the way, just one question. I'm sorry, people are still writing me about joining this call. So just before we'll dive into the questions that I've made. Maybe the question we're all asking, and I don't know if you got a good answer for us, is where are we at COVID? I mean, people are talking about a second wave. I'm in Rye. We have partial school. So at least that. In Montreal, we have a lot of friends in Canada, as you can see behind me. Situation is very bad. We are originally from Israel. I think Israel is also not doing that well. But Montreal, for instance, 2 weeks after they came back to school, and they came before us, they started the year before, they already told me, and it was a call I had 2 weeks ago, and already then they told me over 20 schools, if I'm not mistaken, in Montreal have already at least one case of COVID, and things look very bad. And I think it doesn't get better. And in the US, we know the situation. I guess, in a way, I know Portchester and other areas are actually closed for school, but at least here, people thought we'll be quarantined and school will stop very, very soon after it started. And knock on wood, we had a case here and there, but still things go as normal. What do you see on your end? Do you see a second wave really happening to us right now? Are numbers going higher? And maybe ask you also the questions everybody's asking, and probably I shouldn't ask, but I'll ask just as well. From your wild calculated guess, when it comes to the vaccine, do you really see it happening by, like people say, the end of the year? Trump's actually promised us already a very easy vaccine coming in a week or so. But how do you see the second wave? What's going on right now? Are things as gloomy as it might be, or where are we?
I think it's a fair question. Nationally speaking, we're in the grip of a third wave. The third wave, yes, and the numbers don't lie. The numbers are basically that we are now having peak national cases, so as many cases as we were getting in April. So it is. It's a little disappointing to see that happen. It's especially disappointing when you've, as a healthcare worker, when you've been through the initial wave, and now we see these things happening again. It's important, I think, to point out from just a science communication point of view that this was predicted. Cold weather would bring more cases. We predicted this. We predicted that going back to school would bring more cases. These are ideal models for community transmission. And so, as predicted, cases are going up. New York has been doing better than the rest of the nation. So there have been cases increasing. Certainly in the hospital, we're seeing an increased number of cases compared to the last 3 months average. But thankfully, we're not seeing as rapid a rise as we did in April and May, which indicates to us that the suppression techniques that are being used, such as shutting down businesses in certain zip codes that are showing increased percentages of positive testing, are having an impact on maintaining numbers at a manageable level. But certainly we're seeing an increase in numbers. In terms of vaccine timing, I am certainly not a vaccine expert. I was, however, on a panel just last week with a vaccine expert, which is Dr. Florian Kramer from Mount Sinai. He's an amazing immunologist and virologist who has been at the forefront of the bleeding edge research going into vaccine development. His projection on the panel, which was an internal medicine conference on the panel last week, was that late January, early February would be the earliest we'll get a vaccine, so long as phase 3 trials continue to go as well as they're going right now with the companies that are running the trials.
We're, I would have thought, looking from the outside in, not as an expert, that our situation could be even worse now, because when it started in March, we were at least getting into the warmer season, and now we are worse because cases are going high and we're entering the cold season. But you're saying that basically what we learned and shutting down restaurants and all of that puts us in an advantage that should, put us in a better place than otherwise we would have been, comparing the 2 seasons.
Yeah, well, once again, I think it's important to point out that the numbers don't lie. So the cities and the states that are not following best practice protocols, I think Florida is a really great example of this. They are not following what the CDC is recommending. They are not following what Dr. Anthony Fauci is recommending, and their numbers are spiking. We are following the science in New York. And as a result, we know how to suppress these things. We know how to suppress viral spread in viruses that are spread by droplet transmission. And a really good example of this, which was cited by Dr. Fauci from my home country of Australia, is that Australia made it through winter because in Australia, everyone was religiously socially distancing, staying at home, wearing masks. They had the lowest rate of flu virus in the history of tracking flu virus numbers, because, like the coronavirus, the flu virus is transmitted by airborne transmission. And because everyone was doing all of the protocols necessary to suppress airborne transmission of a virus, the country had the lowest ever rates of flu virus transmission. And I think that that is a nice example of how suppression techniques in one instance can apply to suppression techniques in another instance, and show us that these protocols really do work.
And just one last question about this. I mean, when you look at the Swedish model and you look at your peers in the Swedish health system, have you stopped taking calls from Swedish healthcare folks since then? How do you see that?
Well, I mean, listen, we don't stop taking calls. My belief here, and I think that the health system stands by me, is we can't control people's actions. We can control our actions. So we just continue to help, and we'll continue to fight the fight. Do I wish that things were different? Yes. Do I wish that people weren't throwing around terms like herd immunity? Absolutely. But the reality is that these are hard times. People are making their choices. I don't have the right to, I don't have the right to force my opinions on other people, but in the meantime, we're just trying to help as many people as we can and save as many lives as we can as this crisis unfolds. So
personally, you wouldn't agree with the Swedish experiment, or I don't know how to call what they...
Yeah, I mean, I think that it was in some ways a natural experiment in herd immunity. It was in some ways, it was a high risk experiment. And my opinion on all of these things remains the same. I think we need to really understand the stakes when we take these risks. Personally speaking, in my personal opinion, I was against reopening the schools. Now, I understand that other people have other opinions, and I don't have kids. I'm not sending my kids to school. So I understand how other opinions are, valid, and that's it. But from my point of view, the reality was we were setting a line in the sand and saying a certain amount of people getting sick and dying is okay. A certain amount of children's lives being lost is okay. Now, that's a tough pill for me to swallow, but being, in the position that I'm in. I believe in complete suppression of the virus. Again, I will harken back to my home country, because I come from Western Australia, where they haven't had an active case in around 6 months and life is back to normal. But their lockdown protocols were incredibly strict. They would shut down zip codes. They went zip code by zip code and said, you can't leave your zip code. And if you're caught, the police were patrolling. If you're caught leaving your zip code, you get hit with a massive fine. And because of that, they suppressed the virus. They had not a single case of community transmission. And now they've locked down their border from all of the rest of Australia that wasn't as strict as they were. But they've had no cases in 6 months. And I call my family, and life is back to normal for them. It swings and roundabouts. There's no one absolute right answer, but we can't completely ignore what's going on in other locations.
Fascinating. So you're the Director of Rehabilitation Innovation for the Mount Sinai Health System, but it seems as though your team has been heavily involved in pandemic response. Why is that? Isn't this outside of your scope?
Yeah, well, when I think about my role within the Mount Sinai Health System, initially, the role as it was described to me was if there is a technology out there that you can find that will help really disrupt the way that we provide clinical care to our patients, we want you to find that technology and relentlessly pursue it until everyone in the health system is using it. So my role really is to scout out the best technologies that I think can really elevate the standard of care and the quality of care that we provide to our patients and the people that we serve, and get it out there. So I'm really blessed to have a team that shares this mission and that shares this vision very, very aggressively. And so the moment the surge hit New York City, immediately my team organized and they said, okay, what do we need to do to help? How do we help the community? And so initially, it was simple stuff. You know, we started putting out infographics and information about this is how you order groceries online if you're an older adult, so that you don't need to go to the grocery store. This is how you can get your medications online. This is how you can get all sorts of different services delivered to you if you're in a health compromised position. We distributed that content in multiple languages, and we also distributed that content in ways that individuals of all wealth disparities could access it. So these are delivery grocery stores that accept food stamps. These are delivery pharmacies that accept Medicaid and Medicare, so that, you know, it was very universally designed so that anybody had full access to what was going on. But then very quickly we saw that there were a lot of people in need of healthcare, and we immediately saw this big glaring problem with the COVID-19 response, which was we were telling people to stay out of the emergency departments unless they were really, really sick, you know, so don't clog up the emergency room unless you really feel it's an emergency. But there's a problem there, which is no one knows the disease course and no one knows what is really an emergency or not in this case. So we rapidly took a program that we were actually using to track stroke survivors and monitor them during their post-discharge, first few months post-discharge, to prevent them from having a second stroke. And over a period of 24 to 48 hours, we went into the app that we had to monitor these stroke patients. We completely changed it so that it focused on symptoms of COVID-19. And we released it to the public as a way to track symptoms and inform a Mount Sinai clinician on a daily basis. We made sure that somebody would look over your data on a daily basis to make sure that your symptoms were not getting out of control. We called that program Precision Recovery, and from the minute we launched it, we had hundreds of people signing up. We've managed the care of almost 2,000 people with COVID-19 as a result of, you know, just the amazing sort of press coverage that the app picked up in the middle of the New York City surge. And it really was this amazing program that saved a lot of lives. And since the surge has eased a little in New York City, although we're still managing a lot of care through Precision Recovery, we've also started to be, in collaboration with the Center for Post-COVID Care, one of the leading groups managing the rehabilitation of people who are exhibiting symptoms of what we now call post-acute COVID syndrome. You may have heard this in the media as being called COVID-19 long haulers, or sometimes long COVID. These are individuals who months after their infection are experiencing incredibly debilitating symptoms. Once again, we've just found the need to step up and apply the latest in technology and rehabilitation solutions to these patients.
Fascinating. By the way, do you feel, you know, you mentioned you're dealing with hundreds of patients. I mean, you're right there in the forefront of everything, and you guys you and your peers, you feel protected enough now that you have, I guess, better masks than they had when it all started? So you feel, you're in the middle of it all, and you look calmer than me. So.
Yeah, I think right when things got quite bad, we did go through a crisis where we were concerned that we were not going to get the masks that we needed or the PPE that we needed. Once again, in terms of, I think at the beginning I said there were low points and high points. An incredible high point for us was just seeing the community rally together to get us PPE. In the early phases of the surge, we had people showing up and delivering little boxes of PPE that they had lying around the house, making sure that until we got the supplies that we needed, which was very quick, but in that short period where we were concerned, oh my God, maybe there's a shortage, maybe we won't have enough, the community really stepped up and helped us out, which was amazing. Now, we're very fortunate at Mount Sinai that we have the PPE that we need stockpiled should another serious surge come back. But being in the hospital is great. The protocols that they've enacted to make sure that we stay safe are really effective. Everybody gets screened as they enter. A lot of the unofficial entrances to the hospital have been closed down so that everyone has to go through common entrances to make sure that they go through the screening process. We have a lot of contact tracing protocols in place. The hospital is doing a really good job of making us feel safe as employees.
Now, what have you learned about innovation in crisis? How has it changed your approach or changed any thoughts or what you already know?
Yeah, I think that one of the things that I always advocate for in terms of helping organizations to become more innovative. One of the phrases I always put out there is always be mission-oriented and not compliance-oriented. There are a lot of organizations, especially large organizations, that are highly compliance-oriented because they often lose sight of their mission, and they say, well, our job is really to just keep doing what we're doing, not get sued, not take on any large risks, not do anything that will rock the boat, just keep on the trajectory that we're at. Very risk intolerant, but therefore very compliance oriented. Innovation is all about risk, though, so it doesn't really jive with an organization like that. And so places where I can be innovative have to be mission oriented. They have to be about what is the mission of the organization and how are we constantly trying to better ourselves to fulfill that mission. And one of the incredible things that happened with Mount Sinai, Mount Sinai is a big organization. It's got 40,000 employees. It's the largest employer in New York City. And so obviously there has to be some level of bureaucracy and compliance in an organization of that nature and that size, which can make things challenging for innovation. But one of the things that happened during the surge was all of those walls came down. From the highest level of leadership at Mount Sinai, the message that was shared with us was, if you can save a life, if you can do something to help the community that we serve, go and do it. And it was not a call to be reckless. It was a call to just be useful. We're in a crisis. We're in a fight. Get out there and do what you need to do to help people. The institution has your back. And that was just such a strong example to me of being mission-oriented and dropping all of the compliance for a brief moment. Because again, compliance is important. It keeps people safe. But in the middle of a crisis, what you need is an elevated level of mission orientation. You need to understand, what are we here for? Okay, we're here to help people. We're here to make sure that people remain safe. And in the midst of a crisis, all of the rules that typically are there to protect the institution around haphazard innovation, they don't matter. What matters is that we do everything that we can to help the community.
Now, resilience is often thrown as a buzzword everywhere these days, but very few have gone through what you guys went through at Mount Sinai. So what have you learned about resilience?
Yeah, resilience is a big buzzword in organizations. One of the things I think is very important, a very important lesson that we learned here during the crisis is that resilience, we often think about it as a quality of a person. We tell doctors and soldiers they need to be more resilient. We tell organizations that their employees need to be more resilient. But one of the things I think is really important and was really emphasized during this time, this very difficult time that we experienced, is that resilience is a social resource. And all of the latest research in neuroscience, as a neuroscientist, about resilience points us to this idea that resilience is a social resource. So what actually makes people resilient is understanding that their team has their back, understanding that they belong to something. And you just cannot create resilience within an organization if you're constantly signaling that only the bottom line matters, everybody is expendable, so on and so forth. What really matters the most in building a resilient culture is letting everybody know that the institution is there to protect them, the institution has their back, and then on that's important from institutional messaging, and then the messaging has to be really amplified at a sort of organizational level all the way down. So every leader within the organization needs to be signaling that to the people who report to them. And, one of the things that we really experienced during the surge was we had our leadership showing up. We had the president of the hospital, David Rich, showing up on the ward to just tell people that they were seen, they were heard, and they were appreciated. People going through some of the most clinically challenging periods of their life, and on a humanity level, some of the most humanly challenging periods of their life. And they had leadership of the hospital showing up to tell them that everything was appreciated and that they were heroes. And one of the things that we kept seeing was these really beautiful moments of bonding between individuals who ordinarily didn't say all that much to one another, didn't really interact all that much. All of a sudden, we were in this shared experience. We really, truly did feel that our institution had our back and that our leadership had our back, and that we were all pulling together toward a common goal. And I think that level of signaling is what creates resilience. And trying to get through something like this when you're feeling alone, when you're not feeling that level of support, is you can be as resilient as you want. You can be personally resilient. You won't get through. You need the team, you need the culture to help you get through this.
You've been involved in the remote monitoring of patients with COVID-19. Can you tell us more about that and the program that you built?
Yeah, so the program, like I said, was called Precision Recovery. It is called Precision Recovery, and really, it's just about following a very simple principle of remote patient monitoring, which is when you don't understand a disease, when you have a novel disease, the only way that you're going to be able to manage someone's symptoms is to make sure that you're closely watching. And the closer you watch, the more important information that you're going to pick up about someone's health status. It really is as simple as that. And the gap that we were filling here was people were trying to protocolize care of COVID-19 like you would any other health condition that we understand the clinical course of. But the problem here, of course, was that we didn't understand the clinical course. New symptoms were arising every day. New odd presentations were arising. New side effects to medications. 1 minute the French government was saying it's not okay to take aspirin. The next minute they're saying, oh, actually it is okay. You better take aspirin. 1 minute we didn't know anything about loss of sense of smell, and the next minute it's central as one of the leading things that you should be looking out for in COVID-19 infection. So building out this mobile application allowed us to create a learning health system where we were tracking and auditing symptoms of thousands of patients all at once. And we were rapidly learning, and we could quickly disseminate that knowledge, not just to our own physicians, but to physicians at health systems all over the country and all over the world. And signing up to the program was really, really simple. We just had a hotline that you text COVID-19 to the hotline, and someone would call, sign you up, and make sure that on a daily basis, someone would see the data that you provided. On a weekly basis, someone would call you up, talk through your data with you, make sure that you were doing okay, take care of any needs that you needed taken care of. And then finally, if there was a time when your metrics weren't looking good, someone would call up and make sure that you were doing okay. And if you weren't doing okay, they would escalate your care to an emergency department or a medical doctor, whatever was needed in the moment. And it really was that simple, but it was a very necessary service, especially during the initial surge.
Maybe I should talk to you about that later, but we had a company, Israeli company, presenting a couple of weeks ago that does exactly that, help monitor from afar by even understanding the moods of people. And it's something very interesting, also by how their face looks like. And
it's not being AI, is it?
No, it's a combination of things. It's also measuring stuff on you, and it also tells from if you're in pain or, it's very interesting. And maybe I should put you guys in touch. Very interesting. She's actually the daughter of one of Israel's most famous entrepreneurs. Yeah, and the other partner came from a secret division in the Israeli army where they developed that technology that they use now. Long story. Anyway, I'll share it with you later on. In the course of providing care to COVID patients, what have you learned about the virus? What are some of the most unexpected things that you've discovered?
I think, one of the most important things that we have learned is that a large proportion of individuals, somewhere in the neighborhood of 20 to 35% of individuals that experience COVID-19 infection have long-term signs and symptoms. Now, that can be extended periods of lung and heart damage as a result of the virus. It can be extended debilitation because of how long that they were in a hospital bed or on a ventilator. Or it can also be this new viral syndrome that we are seeing, that we have named post-acute COVID syndrome, that by our numbers, so looking at our particular numbers, we're seeing it accounts for about 10 to 15% of COVID-19 infections. And it really is this whole body syndrome that has a lot of different symptoms associated with it. That is as a result of, so it's not an active viral infection, but it's as a result of the inflammatory response that the virus has caused. Our autonomic nervous system gets thrown out of whack, out of balance. And so this 10 to 15% of patients that we're seeing, we're currently managing around 450 of these cases just within my center. They have extreme fatigue, heart palpitations, high heart rate, all sorts of dizziness, headaches, chest pain, difficulty breathing. And these are symptoms that persist for months. The other thing that is really alarming about this particular syndrome that we're tracking is that the average age is around 40. And most of the people that we're seeing were previously fit and healthy. So the majority, around 70%, these are people who ran marathons, exercised frequently, lived in good health, no prior conditions. And the aftermath of the virus is really wreaking havoc on their system. And we're measuring recovery in months. The recovery process is very, very slow. So we've only had, since people started coming to us in April and May with this syndrome, we've only had a couple of people fully recover. The rest of the people are still going through a program that, some have been enrolled in for 6 months. And so this is one of the reasons why we're strongly advocating for everybody to stay indoors, socially distance, wear masks, practice good hygiene, because this is not just, death rate is not the only number that matters here. This is not just, a problem for older adults. This is a problem that we're seeing in young individuals who were previously fit and healthy.
So when people told us when it started, the flu kills more people every year, it's just over, exaggerated in the press. So that's not the case. It's actually something vicious way beyond and more dangerous.
Yeah, I mean, I think the death toll in this country has shown us very, very clearly that this is, first of all, more deadly than the flu. Second, more contagious than the flu. But now these long-term effects, the fact that somewhere in the neighborhood of 20 to 35% of people are requiring months, if not years, to recover from the virus, that is a very concerning differentiation from a simple virus like the flu.
And when they said in the beginning that if you're a smoker, then you're in a worse condition because it has to do with the lungs, is that how it is? Because what you're saying is basically that healthy people got it worse than just like anybody else.
It's an interesting thing you bring up there. I want to be very clear that I am not saying go out and smoke. That is certainly not what I'm saying. But actually, there is some interesting literature showing that long-term smokers, because of the presentation of a particular receptor called the ACE receptor in their body, which is actually how the virus gets into our system, there has been suggestion that long-term smokers may have a slight protective effect on from COVID-19. Now, this is not saying that people should go out and smoke, but because you have to smoke for years to build up this sort of change in receptor density. But interestingly, there has been this odd affiliation with long-term smokers and less severe viral infection.
Unbelievable.
One of these twists of fate that happens sometimes.
So my next question is about long haulers, but I think you mentioned that. Now I understand that many essential workers at Mount Sinai experienced some hard times during the initial New York surge. What was your response for this? I think we talked about it as well, but I would love to hear if you have anything to add here.
Well, yeah, actually, one of the things that my team did, so as you mentioned at the beginning when you were introducing me, I do a lot of very diverse work within the health system. And in addition to working a lot with patients, we also work with high performance athletes. And one of the teams that we work with is the Brooklyn Nets. And one of the things before COVID struck, one of the things that we were working on with the Nets was this idea of creating a space where players could enter the space and have their physiology calmed down after a game. Because, you know, one of the things that they were thinking about was, okay, how do we create this, when the players finish a game and they're completely wired, they don't sleep well, they're bad at training the next day. How do we create a space that can calm them right down? So for about a year, we had been planning this out and thinking about how we could do it. And we had a bit of a blueprint for creating a room that we called a recharge room that was specifically designed using, you know, the best neuroscience that we had to just bring people's physiology down, bring your heart rate down, bring your blood pressure down, relieve stress. So when the COVID-19 crisis hit New York, and I was seeing all of my colleagues just going through incredible stress that they'd never been through before, I teamed up with one of our partners on this work, which is a design firm called Studio Elsewhere. And we just said, you know what? Let's just build the recharge rooms. One of my labs called the Abilities Research Center, which is in the Mount Sinai Hospital, it's 3,000 square foot of clinical research space. Now, during the surge, that wasn't being used because we had to shut down all of our research. So we had this big space sitting in the hospital completely unused. So we came in and we completely transformed the space from a clinical environment into, if you can imagine, it looked like a day spa, you know, soothing light, essential oil diffusers. We had purpose captured natural scenes that we followed the science of specific scenes that are known to create a specific effect in our nervous system called soft fascination, which calms our nervous system down. And then we, you know, completely surrounded people who were sitting in a seat with all sorts of greenery, because again, there's a large body of literature around the calming effect of green spaces. And we set these rooms up and we sort of just started sending text messages out to people and saying, hey, if you need a break, just text us and we'll book you some space so that you can, you know, calm down and relax. And we didn't really expect too much in terms of interaction, but we made the space available. We felt good about that. And over the course of 2 months, we had 13,500 people come through the space to experience the recharge rooms. Our data that we were collecting at the time, we just asked people to answer a few questions before and after having the recharge room experience, showed that being in the room for 15 minutes resulted in a 60% reduction in the stress that they were reporting. And really the response was overwhelming. And so actually, thanks to a wonderfully generous donation from the Kuhlman family, which is a family that has philanthropically been supporting the Kuhlman Institute here at Mount Sinai, which is an institute focused on improving patient experience. We were able to create these recharge spaces in all 8 of the hospitals around Mount Sinai, so that all of our frontline workers, and this is not just doctors and nurses and healthcare workers, this is mailroom workers and janitors and, you know, and our food, food services staff, all of the people who were coming to this incredibly stressful environment could have a space they could call their own to calm down and just try to soothe themselves from everything that was going on outside.
What you're talking about is amazing. By the way, we're getting questions from all around. I'll get to it in a second. So basically, we're dealing with a disease that gives me a good reason not to see my mother-in-law, go to do spa, and go back to smoking. Maybe it's not that. No, sorry, I had to make the thing. So what I want to ask you, I mean, we got to laugh, a little bit, otherwise, we need to cheer people here. So you talked about the concept of the rooms, the recharge rooms. If you want to add anything, let me know. But we do have some questions from the audience. But another question here: after interacting with so many frontline staff during such a stressful period, do you have any comments about burnout? Are there new insights that we can take away from this experience about managing burnout and maintaining the well-being of the hospital staff?
Yeah, I mean, I think that these are broadly relevant to everybody, because I think that everyone is experiencing collectively a bit of burnout right now, whether you're in the thick of it at the front lines, or if you're sitting on the sidelines wishing you could be in the thick of it. I think a lot of us feel that experience of, I just want to go in there and help, which is also exhausting and has its own sense of burnout. I think that a couple of the important lessons that we learned were first and foremost, many of our staff, let's talk about the difference between trauma and burnout. Many of our staff experience trauma, but when they were working toward this very important mission, which was to keep New York City safe, many of them were reporting to me, I don't feel burnt out at all. I'm seeing some terrible things. I'm experiencing terrible things. But my burnout levels are fine because I know that what I'm doing is very important. I know that I have purpose. I know that I have a mission. And I know that I just need to keep going until the virus is gone. So it was interesting to me and surprising to me that many of the people who were working long hours and really pushing through some harrowing circumstances were not feeling burnt out. They were acknowledging that there was trauma that they were experiencing that had to be processed and had to be worked on with professionals. But they were also acknowledging that they felt that they could keep going because they knew how important what they were doing was. And this is something that we've been closely monitoring because, of course, as you might imagine, there can be fallout when the urgency ends and you have to go back to regular life. You have to go back to practicing medicine, and now all of a sudden you don't feel the urgency. You don't see the big mission right in front of you. This is what we're worrying about with many of our physicians, that they might think, oh, well, what's it all about now? Because back during the pandemic, I knew what my mission was. Now, what is it about? Is it about how many patients I see in a day and how many bills I drop? Or is it about, what is my mission? So we're working with a wonderful center that has just been stood up, which is focused on well-being, resilience, and personal growth. It's really a center that is the first of its kind, that is focused on helping all of the Mount Sinai employees maintain a good sense of mission, manage all of these really difficult feelings that they're having related to trauma that they've experienced, as well as, what is next after all of the sort of horror of the pandemic fades. So that has been a really, interesting experience. The other thing that I think that can't say often enough is that we need to just let people have their emotions. There was a lot of sentiment initially that I was reading in medical journals about pathologizing emotion. If someone starts crying, you should send them to a counselor. One of the things that I was learning was people were having an emotional experience. They would come to the rooms, they would get angry, they would get sad, they would laugh. It was emotional release, and it was something that was necessary for them to get up and go back and do their job. And the more that we try to pathologize emotional release as opposed to actual emotional issues as a result of trauma, the more that we're going to make people feel bad about reporting emotional release. We're going to make people feel bad about allowing themselves to release their emotions. And that leads to burnout. If you can't feel your emotions, if you're not feeling that you have enough psychological safety in your own workplace, that you can just show the real emotions that you're feeling, that's what makes people burn out, because that requires a lot of cognitive effort to hold it all in. Whereas if you're in a safe environment and you feel it's okay for me to have a cry right now because I know that my workmates understand what I've been through and I can have this emotional release, I can feel better afterwards and I can go back to doing my job, that is what prevents burnout. Not tagging people, oh, that's negative, they just cried, they need to go and see psychologists. That isn't helping. So that was a really big insight for us.
Now, maybe my final question before we have some other questions here is, what's next for the recharge room concept? And basically, how can families help? How can families get involved and better understand maybe the idea here is how they can support? Can they, what are we offering actually the families nowadays to get involved with what you do as well? So 2 questions here: future, next steps, and this.
Yeah, I mean, in terms of the recharge rooms, we're trying to do 2 things. The first is make them more widely available, both within our health system and within other health systems. And we're also trying to make them available to patients as well. One of the things that seeing the effect that it had on my colleagues and seeing the calming effect that it had, immediately we started thinking, how can we use this to enhance the patient experience while they're in a really difficult, stressful, traumatic experience? How can we create these experiences and make them universal for both clinicians and patients, so that even there are shared experiences going on? The other thing that we're working on with the recharge rooms is how can we create environments that express other emotions? So the recharge rooms were great for stress relief, but imagine if we could create a room for amplifying focus, so that a surgeon who needs to get their head on straight before they go into a difficult procedure can spend 10 minutes in a focus room and come out more focused. So we're working with a number of really amazing cognitive neuroscientists on exploring that concept a little bit more rigorously, to try to understand how we can really expand the emotional range of the recharge rooms and have them, be a little bit more multimodal than just come into this beautiful room and experience some stress relief and relaxation. So those are really the next steps for that particular project. In terms of engaging with us, we absolutely we need help. We need help to continue growing all of these programs. Like I mentioned, just with the long hauler program in general, this is entirely unfunded. We're trying to provide care to as many patients as we can. We have a wait list right now into December, January to see patients. All of our clinicians are completely overwhelmed. So anything that can be done to support our programs, to allow us to hire more people, to bring on more doctors to manage these cases, and to provide and to conduct the necessary research to understand these conditions more deeply, are really, really important right now, because it is an ever-changing situation. And what we do know about post-viral syndromes, such as post-acute COVID syndrome, is that the longer it takes us to deliver care to people with these symptoms, the longer it takes to rehabilitate them. And so we are trying desperately to get as much care as possible out to as many people as possible, but we need the resources to do so.
We will send your contact information, maybe not yours, but whomever will on your behalf, so people can get engaged later on. So let's see, David, we are in discussions with MSSH regarding contactless temperature monitoring and tracing that provides data to the hospitals as well as Department of Health. What kind of system does MSSH has that provides a seamless system to allow visitors through the point of entrance into your facilities?
Yes, so currently, everybody who's entering the Mount Sinai Hospital has a contactless temperature taken, and a series of 5 symptom screening questions that were released by the CDC based on data from the World Health Organization about appropriate screening for potential early COVID-19 infection. And like I mentioned earlier in the conversation, what we have done is very, very severely limited the number of entrances that Mount Sinai, that anyone trying to enter a Mount Sinai hospital can enter through, so that every single person, staff included, so every single day I need to go through, and then I receive my screen sticker, and I've only been in my lab right now, but as soon as I leave my lab, I need to wear the screen sticker so everyone knows that I was screened when I entered the hospital. That is how we're currently managing. Now, in addition to that, anyone who starts to display symptoms, whether it be a patient or a Mount Sinai worker, they are asked, obviously we don't have 100% control over this, but they are asked to report that back to us so that we can then contact trace and inform everybody who entered the hospital through the same entrance each day to make sure that, we can do the responsible thing and make sure that everyone's informed that there's a possible potential exposure.
How do you work with Dr. Valentine Foster on his willingness platform to curb cardiovascular issues?
So Dr. Fuster and I have actually just recently got to know one another, and he's actually incredibly supportive of our recharge room initiative, and he wants us to start to transform some of his spaces. Working with Dr. Fuster and the cardiology department has been crucial for our long hauler program, for the post-acute COVID syndrome program, because every single patient that we see has to have cardiac clearance before proceeding to rehabilitation. So every single patient that we see needs an EKG and an echocardiogram. And we are incredibly thankful to Dr. Fuster and his colleagues for making sure that that is a priority for every patient that we refer to them.
I will choose maybe one or two more questions, and again, we will send more information later. So given the impact of COVID-19 throughout the body and the post-COVID-19 diseases, is it becoming clear that this is really a disease of the vascular system? Vasculature system.
That is a really good question that we don't have a solid answer for just yet. This is actually one of the things that we are investigating, is how to classify some of the post-COVID symptoms and syndromes that we're seeing. Many of the post-COVID syndromes that we're seeing are directly related to damage of organ systems as a result of COVID-19. Now, certainly we know now that COVID-19 is more than just a respiratory condition. It has action on every organ system that we can think of as a result of the virus's ability to enter cells through the ACE receptor. What I'm trying to do personally in the way that I think about things is not narrow my view or my scope to one system. I think the assumption has to be that COVID can get almost anywhere. And so we need to be very, very prepared for a wide range of symptoms. One of the main things that we are trying to decipher right now in our post-acute COVID syndrome patients is whether the virus is causing these symptoms as a result of endothelial dysfunction or immune-regulated dysfunction that causes autonomic nervous system issues. But it's a very good question, and we don't have a clear answer on it just yet.
David, this has been one of the most fascinating discussions I've held, and I've held a lot. I even asked David before our call to see if he or any one of his peers can join one of our or both of our upcoming conferences online, the Canadian and the US one, and I hope they'll be able to be part of that. David, anything else that you'd like to add at this stage?
Listen to science, stay safe, look after one another.
Great. So it's been a fascinating discussion. I get more questions. Can we get a recording of the session? Yes, we will have a recording of the session. The session is being recorded, and we'll share that with you as well. Everybody knows how to reach out to us if you want to talk to David and his team and us. So David, I thank you very much for your time. I know it's crazy. I don't want to share with you, and yet I am, how tough it was for me to speak to David and his team during this period. He knows how many emails I've sent, how many PAs were involved, but it's really, unlike anyone else that has a good reason. There's no better reason than David's. They're really at the forefront of a crazy battle as no one else is. So I thank you so much for that precious hour you just gave us. I hope we can talk about it some more at our other events. Tomorrow at noon, we open our line of family office conferences for days, starting tomorrow, October. Oh, we should fire our graphic designer because nobody can read the 28th. It's October 28th, which is tomorrow, is our first session. So David, thank you so much. And you will definitely be seeing more of us because we are very persistent and we send loads of emails. So we will get your attention again at a future discussion, even though you're crazy busy here. Thank you so much for helping us fight this disease. And I'm looking really forward to seeing you again.
Me too. Thank you, Danny.
Thank you. Bye-bye.